We are very proud that you join our session today. My name is Stefan Winkler. I am from the Medical University of Vienna, Department of Internal Medicine and Infectious Diseases, and I have the honor to chair the session together with Professor Sanguinetti. He's from the University of Cattolica del Sacro Cuore in Roma. And yes, before we start our session, I have a quick note for those who want to maximize the value of the session today. You see a QR code on the slide, and when you scan the QR code, you have immediate access to the papers that are discussed today. Yeah, it's a brief, it's a summary of the papers, and when you do that, you can instantly see the papers that are discussed. So, because of the tight time restrictions, we proceed to our first speaker. It's Professor Selvarangan. He is the Director of Medical Microbiology Laboratory at the Children's Mercy Hospital in Kansas City. He is the Director of Emerging Infections Program at the Children's Mercy Research Institute and a Professor of Pathology and Laboratory Medicine at the University of Missouri in Kansas City. The title of his talk will be Improving Diagnosis and Management of Patients with Acute Respiratory Infections in the Emergency Department. Please, Professor Selvarangan, it's your place.
Thank you, Professor Winkler and Sanguinetti for the introduction. Very good evening to everyone. Yeah, the title of my presentation today is Improving Diagnostics and Management of Patients with Acute Respiratory Tract Infection in Emergency Department. Here are my disclosures. So in the next 15 minutes, what I plan to do is to cover an important evolution in diagnostic virology. What I really mean by that is the shift from conventional antigen-based testing to point-of-care rapid molecular tests, and to more recently, point-of-care syndromic panel testing. So we will explore this important shift and discuss the need for syndromic testing for acute respiratory tract infections, describe the factors that influence performance of these tests, and discuss value of timely and accurate test results in management of patients in the outpatient setting. In the last few slides, I would share some of the most recent data from our laboratory on evaluation of performance of point-of-care testing for molecular tests for acute respiratory tract infections. So by way of introduction, acute respiratory tract infection is one of the top diagnoses in the outpatient setting. About 10 million outpatient visits occur annually, and children are disproportionately affected by acute respiratory tract infections. On an average, around $40 billion are used in the management of upper respiratory tract infection in outpatient settings. An additional $15 billion is lost in indirect costs due to caregivers taking care of patients. So it is a significant problem. When it comes to etiology of upper respiratory tract infection, we all know viral causes are the leading pathogens. Rhinovirus, influenza, respiratory syncytial virus, and many others that we are very familiar with. When it comes to pharyngitis, which is also one of the common upper respiratory tract infections in the outpatient setting, viruses remain the leading pathogens. However, about 15% of pharyngitis are caused by bacterial agents, and group A beta hemolytic strep is number 1. So the risk factors are many: close congregations, asthma, smoking, allergic rhinitis, immunocompromising conditions. And so these are critical patients that need timely diagnosis, and we need to identify the right test for the right patient at the right time. So when you look at the sore throat diagnosis, despite pharyngitis being a main viral etiology, antibiotics are inappropriately used. So here is some data showing that more than 50% of adults receive inappropriate antibiotics, while only 10 to 20% really need them. And more than half of physicians are not following the recommendations for diagnostic group A strep testing and/or culture. So all of this results in overuse of antibiotic in the outpatient setting at the cost of about $1 billion in overuse of antibiotics, and more importantly, adding another $5 billion in combating antimicrobial resistance that's created because of this overuse. So how can laboratorians help this cause? Before we do that, as laboratorians, we have several tests in our toolkit. You have the cultures, the antigen test of various forms, and then you have the nucleic acid amplification tests. But one has to carefully consider all of these factors before you decide on a test, such as the age of the patient, the type of samples that are being received, and how the assays that you use are going to work with them, the viral evolution over time and emergence of new variants, the timing of the sample collection, exposure to animals, prior use of antivirals and/or vaccination, and more importantly, depending on where your laboratory is set up, the transport time is also going to play into the success of the diagnostic yield. So when it comes to outpatient acute respiratory tract infection testing, 3 things matter: the accuracy of the test, the timeliness, and the cost of the test. So let's look at influenza antigen detection. So influenza testing. So here is a meta-review that shows that the rapid antigen tests are poor in sensitivity. They are anywhere about 50% for both flu A and flu B. The digital immunoassays improved it a bit, but you really need molecular testing, a rapid molecular test, to appreciate sensitivities in the 90%. So we decided to switch from an antigen-based test to a molecular test back in 2019 and provide this testing in the outpatient setting, both in the emergency and the urgent care. These are 2 separate settings, as you can understand. Here, high-risk patients, higher cost, and delay in the overall time, comparatively speaking, to urgent care, where this is low severe acuity, and the time to management of patients is usually in the minutes, usually around 45 minutes, the patients are treated and discharged. So with that in mind, when we implemented this point of care standard nucleic acid amplification test, we wanted to measure the impact of this test in the care of patients in the outpatient setting. So we provided education on the testing guidelines and invited the clinicians in the ED and outpatient setting in the urgent cares to participate in a 6-point survey, asking them on the clinical suspicion of the flu: was it low, severe, or moderate? And we asked them if they were planning to manage the patients with antivirals, antibiotics, additional diagnostic testing, imaging, and/or hospitalization. After they answered those quick 6-point survey, they ordered the test and the results were made available. And after the patient was discharged, we came back and reviewed the charts to see how the physicians used the test results in actually managing the patients. So let's look at the results of the study. So this study was done during the peak of 2019, over a 4-week time period, and we received about 339 surveys. So overall, this was a peak influenza season, so about 48% of the samples were positive, and predominantly a flu A viral season. and the median age of the patients in this study were around 4 years. As you can see, 140 surveys were received from emergency department and 199 from urgent cares. So when it comes to clinical accuracy of tests of clinical diagnosis of influenza in children, it is really poor. So here, when the physicians said the clinical diagnosis was low or moderate or high, and when you compare that to the gold standard influenza testing, it all hovered around 50% margin. In other words, emphasizing the need for clinical testing in the outpatient setting. And here, when we looked at the management of the patients, so the sharp contrast is the use of anti-influenza antivirals. So what happened is really this point here, where many of the physicians, being peak influenza season, were ready to treat these patients. But once the test results were available, they did not. And so we reduced antiviral use by more than 97% in this patient population. So overall, when we looked at the patient management, nearly 70% of physician decisions were changed by the availability on an influenza test result. Most of this driven by the lack of use of antivirals or antibiotics, followed by reduced laboratory testing, imaging, and/or admission decisions. So when we really looked at the overall cost of all of this, in avoidance of additional costs, we saved about $150,000 in the matter of 4 weeks in 339 patients. When we extrapolate this over a usual influenza season where we test several thousand patients, we could save more than $1 million just in avoiding anti-influenza medications by using accurate diagnostic testing. So in conclusion, from this first study, clinical diagnosis of influenza in children has poor accuracy. Implementation of rapid molecular tests for children in the outpatient setting improved antiviral use, more specifically for the flu-positive patients appropriately received antivirals. Overall, clinicians changed 76% of their original management plan after availability of influenza test result, and majority of these changes were in favor of avoiding unnecessary expenses with the potential of overall cost savings for the entire healthcare system. So with that, I'm going to switch gears and move towards syndromic panel testing. Now, BioFire Spotfire respiratory sore throat panel was just approved a year ago. And so we wanted to look at the performance of this compared to the 2 other rapid point of care molecular tests that were available in the market, which is the Cepheid Expert Flu AB RSV SARS-CoV-2 test and the Cobas Influenza A, B, and SARS-CoV-2 testing. So just one slide on the Spotfire respiratory sore throat. Here it is 1 pouch, and you have 2 panels. With 1 pouch, you can test for both pharyngitis and/or upper respiratory tract infection. You collect the appropriate sample type, the throat swab for the pharyngitis and the nasopharyngeal swab, and up to 15 or more pathogens are being detected by each of these test panels. So for the purpose of our study, we wanted to look at the 4 most common viral pathogens. So we selected 250 samples, 50 flu A, flu B, RSV, SARS-CoV-2 positives, and 50 negatives. And we compared them, we tested them on all 3 platforms, the Cobas, the Cepheid, and the Spotfire. And we considered a composite gold standard to which the performance of each of these panels were compared. And if there was a discrepant result, we extracted and tested it by Quant Studio singleplex PCRs. When you look at the results, overall, very good comparison between all these platforms. So we had an overall positive predicted agreement and negative predicted agreement, which exceeded 95% for all of these test systems and viruses, except for one exception where Cobas had 9 false negatives for SARS-CoV-2, and therefore its positive predicted agreements was slightly reduced about 86%. Another interesting finding is because Spotfire has many more targets compared to these other panels, we had an additional 102 detections in this 200 samples. So nearly an additional 50% diagnostic yield with many of these viruses. So all of this is going to be helpful in an outpatient setting in possibly avoiding additional antibiotic use. Now, when we did a workflow comparison of these 3 assays for a batch of 10 samples, overall, the hands-on time were pretty comparable between the 3 platforms, between 1 to 3 minutes. But the results were earlier for Spotfire at 16 minutes, followed by Cobas at 20 minutes, and Expert at 40 minutes. As I mentioned earlier, time is of essence, and especially in urgent care, when the physicians are seeing the patients and trying to discharge them in 40 minutes, the time to result is going to be very important. So one slide on group-based strep molecular testing. As we all know, the antigen tests are the first line followed by culture. And now we have option to use molecular testing, which one test result and immediate patient care possibilities. And again, here is data to show that rapid antigen test performance is poor. The sensitivity range anywhere from 44% to specificity on the lower range could be 69%. So it helps to use molecular testing in these outpatient setting to appropriately manage antibiotic decisions. So in conclusion, I would like to say availability of syndromic panels is going to provide you the rapid results with improved accuracy. Comprehensive detections of pathogens is certainly going to help medical care systems to realize outbreaks and manage their patients accordingly. Easier workflow and high throughput testing. An overall better understanding of the epidemiology and respiratory illness in children. And there is a huge potential for reduction in overall healthcare costs. Now, the laboratory budget is going to increase, but certainly the benefit of this testing is going to be seen in management of the patients and improved patient care. And the key to implementation strategy should be to consider the right patient population, proper patient selection, the right clinical setting, and the physician engagement before we offer these tests. So with that, I conclude, and I'll come back later for questions. Thank you for your attention.
Thank you very much, Professor Selvarengan, for this very interesting presentation. So it's time to move to the second presentation, and the speaker is Professor Alessandra Bandera, who is the Director of the Infectious Disease Unit at the Policlinico Hospital in Milan and Associate Professor of Infectious Diseases at the University of Milan. Professor Bandera dedicates her clinical and research efforts to multi-drug resistant bacterial infection and to the management of infections in critically ill and immunocompromised patients. So the title of the presentation of Professor Bandera is Evaluating the Impact of Pneumonia Panel on ICU Therapeutic Strategies, Insights and Future Directions. Please, Alessandra.
Good morning to everyone. Thanks for the presentation. It's a great pleasure for me to be here at ESCMID to speak about the impact of pneumonia panel on the critically ill patients. Pneumonia remains the leading cause of morbidity and mortality in the ICU, and diagnosing pneumonia in the critically ill patients remains a challenge for clinicians because of the principal limitation of the culture traditional methods that may be slow, and thus the clinician have to rely on empirical treatment, but this strategy has several limitations. First of all, to cover the multi-drug resistant bacteria, but also to have an improvement in antimicrobial stewardship. Thus, the pneumonia panel have some advantages in the diagnosis of pneumonia, especially in the critically ill patients, that relies on the time to results that are very short as compared to the traditional methods. Also the ability to detect some pathogens, not only bacteria, but also the viruses, the high sensitivity, and also the ability to detect some resistance genes. However, I think that the fundamental question is how this translates into better therapeutic strategies in critically ill patients. So I think that data that comes from the studies until now have gained some attention on three potential benefits. The first is the reduction in time to effective therapy, so the patient can de-escalate to targeted therapy from broad spectrum antibiotics. The second is to improve the pathogen detection, because we can check also for some bacteria that miss to grow in the culture, maybe because of the use of antibiotic treatment, and also to detect co-infections, bacterial and viral, that is particularly important in the immunocompromised and critically ill patients. And the third one, maybe the most confirmed in all the studies that have been published, is the benefit in antimicrobial stewardship, because with early detection of resistance genes or not detection of resistance genes, we can decrease the unnecessary antibiotic use and thus reduce the resistance pressure. There are also some limits of the pneumonia panel. First of all, we know that there are some bacteria in the panel, not all the bacteria that can be involved in pathogenesis of pneumonia in the critically ill patients. We know that the data on antibiotic susceptibility rely only on some resistance genes, so it's not enough for all the bacteria, for example, non-fermenting gram-negative bacteria like Pseudomonas aeruginosa. The third is the cost, and the last one is the need to correctly interpret the data in the clinical setting. So in the next few minutes, I will show you some results of the studies about the use of pneumopanel in the ICU. The first is a very nice study, a randomized control study that has been performed in the UK, in which 200 of patients were randomized in the two arms. The first is the interventional group with the use of pneumonia panel in the ICU, and the second one was the traditional method group. So the first result is that the diagnosis is more rapid in the intervention group, a median time of 1.7 hours as compared to 66 hours in the standard diagnostic. The second point is the increase in pathogen detection, 71% in the molecular point of care group versus 51% with conventional testing. The third, that is the primary endpoint of the study, the probability of results-directed therapy was obtained in 80% in the intervention group as compared to 29% in the control group. And the last one, antibiotic de-escalation, was performed in 42% in the intervention group as compared to 8% in the control group. The study was not designed to assess eventual clinical differences in the group, so no clinical outcome has been identified in this study. Another study, very interesting, is this one that I show you that has been performed in the US. It's an observational study, so a pre-interventional, post-interventional cohort in which they evaluated some therapeutic strategies before and after the introduction of pneumonia panel in the ICU in this setting. And they found that their primary endpoint, time to first antibiotic change, was reduced from 50 hours to 21 hours post-intervention, and this was mainly led by the discontinuation of coverage of anti-gram-positive antibiotics and also the escalation of coverage of gram-negative bacteria. The other very interesting aspect of this study is the length of treatment, because days on therapy reduced from 8 days to 6 days, thus improving antimicrobial stewardship items. The third study, I think very, very interesting, is the one that was recently published, 2025, on intensive care medicine, that is the INHALE VUP3. It's a multi-center randomized trial in which patients were randomized to pneumonia panel versus control group. This study has two main primary objectives. The first was the improvement in antibiotic stewardship and was obtained with a gain of 21% in absolute terms. However, and I think also unexpectedly, the second primary endpoint, that was the equivalence of clinical cure, was not demonstrated in this study. And I think that some aspect of this study will be shown in the next lecture, but I think that some insight into this study have to be well considered when we want to improve this syndromic panel in the clinical practice. At Policlinico of Milano, where I work, we introduced the pneumonia panel in the ICU during the COVID-19 pandemic. And thus, after the introduction, we prospectively observed the comparison between diagnosis of ventilatory-associated pneumonia according to what we consider the reference standard, that is the cultural traditional method on bronchoalveolar lavage, as compared to film array pneumonia panel on the same material, so the bronchoalveolar lavage. And as you see in our publication, by a clinical point of view, with the pneumonia panel, we missed two pathogens that had some importance in our casuistic. The first is Aspergillus, that was particularly relevant in this cohort of COVID-19 mechanically ventilated patient. And the second was an outbreak of pneumonia linked to Corynebacterium striatum, that is not a bacteria on target, on panel for the pneumonia panel. But when we evaluated the sensitivity and the specificity of pneumonia panel about the target of the same test, we found a very, very high sensitivity, that is 95%, 100% for some bacterial targets, and a lower specificity as compared to the reference method that was the cultural test. I think that also this point have to be well considered when we use pneumonia panel in the clinical practice, so to gain the real significance of what we found on the molecular target as compared to the cultural one. About our clinical considerations on our cohort of patients and also on our clinical practice, I think that the strand points are principally two. The first is the very short turnaround time, but the second, most importantly, I think, is the ability to anticipate most of the therapeutic choices. Our therapeutic decisions, based on the results of pneumonia panel on bronchoalveolar lavage, were confirmed at the arrival of the test, the cultural test, in more than 80% of the cases. Two limitations I think that we consider when we use the test in the clinical practice. The first is to be aware of what is missing. Beyond COVID-19, I think that the two most important things are to evaluate also the possibility that our patients have some unusual gram-negative or non-fermenting gram-negative bacteria like Stenotrophomonas maltophilia that, especially in the immune-suppressed patients, can have a role. And the second is that in our clinical practice, we found some discordance in the detection of the antimicrobial resistant genes that were detected in the molecular test, but not in cultural test. And I think that this is also to be considered. Different expert opinion documents try to integrate the molecular test into the flowchart for the diagnosis of pneumonia, and most of them recommend the use of this panel for all the cases of hospital-acquired pneumonia and also ventilatory associated pneumonia, but also in the severe community-acquired pneumonia, especially when the patients have risk factors for MDR bacteria or also a very critical clinical presentation. And we also consider the introduction of this panel in our clinical practice based on two things. The first is our local aggregated antibiotic resistance, that is quite what we see every day in our clinical practice. And the second are the result of the pneumonia panel. So when we suspect in ICU and hospital-acquired or ventilatory-acquired pneumonia, we perform the pneumonia panel, and then according to the results of the test, but also on our local aggregated antibiotic resistant, we do suggestion about the therapy. We think that the application of syndromic panels could be very useful also in the setting of ICU patients immune suppressed, and especially we focused on lung transplantation. We think that in this setting where there are a few experience of the use of the panel, we can be useful almost in two things. The first one is to adjust the prophylaxis of the lung recipients based on rapid results on the bronchoalveolar lavage of the donors. And it is very useful because we received the data about the colonization of the bronchoalveolar lavage of the donor only after some days after transplantation. So the patients, the recipients, underwent a standard prophylaxis and not a targeted prophylaxis. And the second one is another aspect that is linked to the duration of prophylaxis in this setting, because various centers have different schemes and go on for 7 days, also 10 days, also 14 days for prophylaxis in these conditions. And we think that to perform the pneumopanel in the first days after transplantation can add us some data, especially if it's negative, to stop the prophylaxis and so to reduce the pressure of antibiotics. So we created an algorithm that we are using in our clinical practice and on which we are collecting also some data that use and integrate the results of pneumonia panel on the bronchoalveolar lavage of the donor and of the recipients in the first days after transplantation, based on which we used to have some recommendation about the treatment. So I think that pneumonia panels are transforming the ICU pneumonia management nowadays, even if some challenges still remain and maybe have to be integrated with clinical practice, with traditional culture methods, and also maybe some other rapid tests that could be added to the management of the patients. I think that in the future we can assist the clinician in result interpretation, maybe with better algorithm, maybe based also on artificial intelligence, maybe combining the pneumonia panel with host response biomarkers can aid us to evaluate the really clinical impact of some pathogens that we found in the test, and also that we need some cost effectiveness analysis to have a broader access of this test in the hospitals. So thank you for your attention, and I look forward for your question and discussion. Thank you.
Thank you very much, Professor Bandera, for already elaborating advantages and disadvantages of molecular testing. And we proceed to our next speaker. It's Professor Omrani, who is a UK-trained infectious diseases physician, and he is based in Qatar. His clinical and research interests focus on optimizing antimicrobial therapy and the management of complex and multi-resistant bacterial infections. So the title of the talk is syndromic testing a key tool in the battle against drug-resistant gram-negative bacteria. Please.
Thank you very much, Professor Winkler, and thank you everyone for being here this afternoon. So what I'd like to do is to focus on the potential role of pneumonia panels specifically in relation to multi-resistant gram-negative infections. These are my disclosures for your awareness. So what we know is about 3 decades ago, we've recognized that patients who have severe infections and have their antibiotics delayed have worse outcomes compared with those who receive appropriate antibiotics earlier. This raised an alarm, quite appropriately, and resulted in very wide action to try to reverse this. The intention was to try to improve the proportion of patients with severe sepsis who receive appropriate antibiotics earlier rather than later. A lot of campaigning, a lot of very good and strong messaging was intended to shift us toward earlier appropriate treatment. But as you all know, perhaps by now, in reality, we've shifted to the other extreme. So we went from under-treating some patients to perhaps over-treating a lot of patients. As far as gram-negative resistance is concerned, this is exactly the required recipe. A lot of antimicrobial pressure, selection pressure, further resistance, and escalating and goes on. This was recognized very early. This is an example of a paper that associated efforts to improve the proportion of patients receiving earlier appropriate treatment, so-called sepsis campaigns, with excessive antimicrobial therapy. The intention was good, but there was an alarm. And as time went by, things started to change and become almost established as standard of care. The ACORN study is a brilliant study. And the subject matter was comparing 2 different anti-pseudomonal regimens. But the reason I'm quoting it here is that the investigators randomized patients who received an anti-pseudomonal treatment, a beta-lactam anti-pseudomonal treatment, in emergency department or ICU. And what they wanted to understand was whether there are differences in toxicity. But I would like you to think a little bit more about the details. So first of all, I'd like you to know that only around 5% of the patients who were enrolled were actually enrolled from ICU. So 95% were from emergency department, yet they were all receiving anti-pseudomonal beta-lactams. Very broad if you ask anyone in this room. In fact, it was an anti-pseudomonal plus vancomycin. The second thing that is even more staggering is that the Institutional Review Board, or the IRB in the institution looking after this study, decided or agreed with the investigators that consent was not required for enrollment for a simple reason. Because patients who are going to be enrolled would receive one of those arms anyway. So we got ourselves into a situation where 95% of patients in this trial, at least, who received an anti-pseudomonal beta-lactam plus a vancomycin were going to receive this anyway. And interestingly, when you look again at the baseline characteristics going forward, 50%, exactly 54% of patients were only labeled as sepsis. So you can see that there's a lot of excessive, unnecessary treatment, and that's something that we need to think about. Societies, including the IDSA, raised a flag many years ago saying, hang on, maybe we need to think a little bit about how do we select patients, a message that was reinforced a few years later, and similar messages were produced by other entities as well. The idea is we need to bring ourselves back into that middle. The extremes are not good at all. One extreme might be associated with worse clinical outcomes directly. The other extreme, evidently now, is associated with increased risk of resistance, which eventually, obviously, is associated with poor outcomes. But the challenge remains, how do we bring ourselves in the middle and allow ourselves to treat our patients appropriately, but also do it in a timely manner? not after a day or 2 or 3, but actually within a few hours. And this is where tests such as the respiratory panel or the pneumonia panel can come in and can make a difference. This is an example from a community-acquired pneumonia setting where patients were randomized to standard testing. That includes cultures and serology and standard testing for patients with community-acquired pneumonia, or the second arm, where all these tests in addition to the pneumonia panel. And you can see very quickly that the proportion of patients who had pathogen-directed treatments was higher where the panel was included. I only bring this up in the context of gram-negatives because in the same study it was also demonstrated that the panel allowed an identification of a larger proportion of individuals with gram-negative infections, including Pseudomonas and Enterobacterales. If we move forward and think about hospital-acquired pneumonia, where we expect to see more gram-negative infections and then inquire as to whether these panels can help us in our attempts to try to reduce the impact and the generation of resistance in the first place. This is a single center study from the US, patients with suspected pneumonia, again, standard testing versus standard and pneumonia panel. Below, I've squared the pathogens that you would expect to see with pneumonias gram-positives, but also a whole host of gram-negatives. So what this table shows is that in this study, the test did what it's supposed to do, which is to identify potential pathogens, including gram-negatives, the subject of our interest. The second thing that you would want to look at was what is the impact of finding those pathogens on decision-making. You can have a fabulous test, we've heard that, and you can have patients on the other end, but you need the link in the middle to connect those results with the correct interpretation to clinical decision-making that actually makes a difference in a patient. To your left, you see that I'm a physician myself, are quite happy to escalate in response to a result. So you can see consistently overall gram-positive or gram-negative pathogens, a clinician hears that there was a pathogen identified that they did not cover, quite happy to escalate. Look at the other end, those opportunities where we could claw back unnecessary treatments and again reduce pressure for gram-negative resistance generation. That works for gram-positives, mostly not detecting MRSA, allowing discontinuation, for example, of a glycopeptide. But there was a huge missed opportunity because de-escalation in response to not finding gram-negatives was not statistically significant. This was an opportunity that as time goes by, we should be not missing as frequently. This is the pneumonia subgroup, and again, it shows the same pattern. You saw this study. It's a single center study from the UK. And what they're trying to do here is bring that test a little closer, actually much closer, very, very close to the patient. So what they did in this intensive care-based study is do the test in the ICU by ICU personnel who were trained on how to handle the samples and how to run the test. So this time from the sample to the result was minimized, which literally 1 or 2 hours. And then immediately those results were transferred to infection specialists, stewardship specialists, who then interpreted the results in the light of all the clinical information and provided advice. The clinicians still chose whether to make changes or not. And as you know, the proportion who had treatments changed because of the results is much higher and much earlier, as you can see in the curve. Interestingly, if you want to put numbers to those efforts, you could see that time to the result is now less than 2 hours compared with nearly 2.5 days. Remember that graph trying to pull us to the middle, where we're making changes earlier because we have better results at an earlier time point. This becomes visibly now, tangibly visible, in less than 2 hours. And then if you look at the proportion who received treatment appropriately, you can see that it's higher, but even more importantly, 2 hours instead of nearly 3 days or 4 days. And then I go to the next part, which is really where we need to focus next, which is de-escalation, stopping unnecessary treatments that were started at the beginning because of clinical concern. Again, within a few hours, 5 hours, rather than days. Imagine the amount of antimicrobial selection pressure that you would take away if we were able to do this more consistently and with a larger proportion of patients all around us. And as you can see in the breakdown, whether it was community or hospital type pneumonias, these tests performed well with gram-negatives of their 3 types, Enterobacterales and Pseudomonas. I finish with the inhaled study. And the inhaled study is truly, or was truly, a brilliant study. It was superb in its idea, in its design, and its ambition. What they tried to do in multiple centers across the UK is to randomize patients with pneumonia, hospital-acquired pneumonias included ICU. Again, the test was brought close to the patient to generate the result as early as possible. And they had more than one endpoint. And these endpoints become relevant as we progress with evidence generation. So the first thing we wanted to know was time. Yes, we know already, less than 2 hours to a meaningful, clinically meaningful microbiological result compared with many days, 3 or 4 days. But then the next question, and I love this about this study, is the calibration. Now, we're not just looking for appropriate, meaning microbiologically active. We're also, was it proportionate? Was it adequate, but not excessive? And that's what they called antimicrobial stewardship. And here you see, whether you're looking at 24 hours or at 72 hours, the proportions were higher where those tests were utilized. The proportion of patients who had the panels introduced into their clinical pathways were more likely to receive calibrated treatment, treatment that is not too much, but not too little. And the ambition continues in this study because they also wanted to take this further and ask, what about clinical outcomes? So they decided, and they are investigators who are thinking through these. This is all innovation. This is not something that has been done before. And what are we going to look at as a clinical endpoint? They chose clinical cure, a composite endpoint of 4 components, including death and relapse and failure to respond. And they set, human beings, they set a non-inferiority margin of 13%. They could have set it at 16, at 19, at 10%. Any of you who was involved in non-inferiority studies would understand that. And the difference was -6%. The confidence interval crosses neutrality of 1, so you can say this is not statistically significant. But according to the methodology of the study, this did not meet the non-inferiority margin of -13. So why is that? Well, the first answer is if you have a result that you don't use, no surprising it has no impact. And what you see here is a staggering 30% compliance only with the protocol. What the protocol stipulated was that once results are made available, there were certain actions to be taken in terms of changes and modifications of treatment. The compliance was just horribly low. Among us, those individuals who were treated according to the protocol, the success rate was 65.5%, similar to the control arm. So you can hypothesize that if we had better adherence, you could have had non-inferiority or even better than this. So the key question is why? Well, the fantastic thing about this study that keeps delivering, and I said it's a superb study, is they built in a behavioral investigation into the study, a work package that specifically interviewed 20 intensive care physicians and asked them questions to explore their attitudes and their understanding and their decision-making. And they explored and they found things that don't surprise, I think, any clinician in this room, especially those of you who sort of round in ICUs and similar areas. A common theme was just in case. We didn't want to stop. We didn't want to de-escalate just in case. I've been hearing this in the last 25 years that I've been in ID. And to err on the side of caution. Caution now is embedded in our brains to treat a lot. Because treating a lot in our brains is not associated with risk. But I tell you, I work in a setting with high rates of gram-negative resistance, and it is a risk, and we need to recognize this. Also, there was clear and obvious skepticism and some unfamiliarity with the tests and what they can perform. And very importantly, the authors make a point that what appears to be a pattern is a mind line. There's a very clear mindset among us clinicians that treating and over-treating is safer, and obviously it is not. And they finish with a beautiful recommendation was that technology is brilliant, but we need something on top. And what we need on top is this education and training. So to finish, gram-negative resistance is undoubtedly a very serious issue, and it is causing us to lose a lot of patients and causing worse clinical outcomes for many of our patients. To be able to address this, we need to get treatments into our patients that is timely, but also not excessive. A tool such as the panel is a brilliant tool that can help us calibrate that treatment and get it into the middle. But an important message has to be that excessive treatment is also probably associated with harm, just as much as under-treatment. No one advocates under-treatment, of course, but over-treatment is also something that we need to start to be concerned about. So the key is technology plus, and that plus is education and innovation in those education efforts. Thank you very much for your attention.
Thank you very much for this very, very nice presentation. In particular, the conclusion are very, very important in my opinion. So I invite the speakers to the podium for the discussion, so please. And if there are some questions from the audience, please. Please.
So my question is to the first speaker. Were the tests performed by lab personnel or by the emergency department personnel?
Yeah, good question, relevant. But for this purpose, that study that we did, comparison was by laboratory personnel. But as you know, these are meant to be done by point of care personnel. And it is made that easy, sample to answer, so few steps. But very good question. This comparison was done by research laboratory personnel, not clinical.
Please.
Okay. My question to Dr. Ali Amrani, thank you for the great presentation. Do you think the best utilization of the pneumonia panel would be for septic patients in the ED? Because, time is very crucial here. And the earlier you give them the appropriate antibiotic, better than waiting for the ICU being sick when many times have lapsed. Thanks.
Thank you very much, Jihad, for a great question. My personal view, that's my personal view, is that the majority of patients in ED with community-acquired pneumonia have predictable organisms, the majority. And our generic antimicrobial regimens for those patients generally are okay. What we need the panels for is to pick the occasional patient who might surprise us. So I think that it is more likely to result in escalation for a small group, but generally speaking, perhaps it would be de-escalation when we identify viruses or we identify likely susceptible organisms. The bigger impact, I think, is the hospital-associated pneumonias, where I think there is a larger opportunity to both calibrate up but also calibrate down.
Please.
Thank you. My name is Nicole Selenko-Gebauer. I'm from Danaher. I would like to elaborate or ask you to elaborate on the technology plus concept. Is it two conflicting or complementary schools of thoughts, thinking about the molecular detection of pathogens versus biomarker approaches that help to differentiate between bacterial and viral, like procalcitonin and others? And how would you connect those two concepts? Is one older and one more modern, or can they complement each other?
Fantastic question. I think the two pathways, if you want, are very similar and can be very complementary. I think they struggle with the same challenge. And that is that I work with clinicians who every day do procalcitonin. If it's negative or low, they continue antibiotics anyway. And if it's high, well, it just confirms what they've just done. And if we apply the same approach to molecular tests, panels, and so forth, then the result is the same. I think they are complementary, and they both benefit from BLUS. BLUS is being education, and education means what does the test mean, how do you interpret it, and also an awareness that harm comes from over-treatment and under-treatment. So they are complementary indeed.
But can I ask you, if you as a clinician can choose both, you have access to both, how many use them both? Or are there more the molecular ones and the ones that do the procalcitonin and others?
I am a clinician. And what I want to ask myself when I come across a patient is there an infection here? If it's clinically evident, then procalcitonin is not going to change my mind. If it's clinically clear that this patient does not have an infection, I think a procalcitonin would struggle to change my mind. I'm a clinician. Mm-hmm. So if I'm forced to choose one, I'll choose a test that takes me to the next level. I've identified a person that they are likely to have an infection. I want to know what is the cause of that infection. So if I'm forced to choose, I would choose a test that tells me the bug.
Thank you. Thank you.
We have one question from the audience again. How to interpret multiplex PCR results with multiple positive organisms? What's the way to differentiate between colonization and true pathogen? It's a question for, I think, for all three speakers.
Yes, I think that is quite a crucial point in the whole day's practice. I think that the history of the patient is very, very important. The history of the patient is why the patient is here in hospital, has already had some infections in the past days, is on treatment for that infection, and what is the clinical picture now. So we have to know all these elements to judge if what we found in the clinical test, in the lab test, is already a colonizer or is the pathogen or already been treated in the past or is actively and so to be treated now.
I have a question, a comment for all you three. So from your presentation, it's clear that the use of molecular tests is very important, is useful for the patients, can aid the patients. So my question from the microbiological point of view is why these tests are not fully implemented in routine. So unfortunately, this is a drawback very important from the lab point of view, because my CEO, the CEO of my hospital, asked continuously that my tests are too costly to spend. Maurizio, you spend too much money for this test. So I think that now we have a solid evidence that these tests are useful. I think that now it's time to implement. And what are your thoughts about this? Because this is very important now, because we produced evidence. So I don't know, which is your opinion about this?
Yes, I read the paper of the Nail study, and also in the text or the discussion, they reported also the cost savings of applying the test. I think that this is quite a crucial point, because I'm not the director of my hospital, but I had to convince him to introduce the panel. There was a COVID pandemic, so all were more easy from some points. But I think that this is quite a crucial point, because if we can demonstrate that maybe some studies based on cost effectiveness can aid, that we have a gain also in the economic part. Maybe this could also another point. For me, I think that I could not be without now in my clinical practice.
Yeah, I couldn't agree more with that point about cost-benefit studies. So it's one of the examples I shared. Just a simple test. Molecular tests tend to increase the laboratory budget, but the benefit is seen on the other side in the overall healthcare management. And so every time there's an opportunity, the laboratorian need to be in those, C-suite and discussing that. And that's really what I do. If I end up seeing the chief finance officer of our hospital, I tell them, hey, our laboratory saved $1 million in this testing, while the budget just increased by a few $100,000. So advocating for good tests and also adding to all our speakers' talk, educating, engaging the clinicians in the dialogue, having them learn what it means to use those tests to improve patient care. because it has to be a two-way street. The laboratory can always do the best, but without the test result being utilized, then ultimately then you will have that come back to say, there's really not much of a benefit. So it has to be a collaboration, active collaboration between the lab, the clinician, and finally the administration to make that happen.
Hi, this is Mushira Hosni, Clinical Microbiology from Cairo University Hospitals in Egypt. I want to ask about the indication and the timing for the BioFire panel for the pneumonia patients, especially in HAP and VAP patients with long-term hospital stay, because we find it challenging, the colonization and the colony count. Do you go back to the colony count results? How are you guided, or do you wait for the culture results to be gold standard or sure for the pathogen that's causing the infection? Thank you.
So thank you for that question. My view is that you should only do a rapid test if you are ready to receive a ready result, a rapid result, and you're also prepared to act rapidly. If the setting is one where you're going to wait for cultures anyway, then there's no point wasting resources. These are very precious resources. The interpretation, as Alessandra said, is really detailed and nuanced and requires clinical sense. But generally, you don't gain much from a rapid test unless you generate a rapid result and act rapidly. Otherwise, if you're going to use normal timescales, well, use timescales. The timing or the indication, at least in the randomized trials and what most people want to do, is they would try to take the sample and initiate the test at the time of the decision making. So when you've made a decision that someone is clinically deteriorated and they've developed a VAP, that would be the best time to take a lower respiratory tract sample, do whatever you need to do to support the patient. Hopefully you'll have the result within 2 hours. That's the definition of a rapid test. And then you need to make a guided decision within 2 hours. But be prepared, whether it's you or your colleagues, be prepared also to scale down rather than scale up. So you might have decided to give 2 or 3 different antibiotics, and now your rapid test is negative. And the intention you did it is because you wanted to avoid a polymyxin, for example. Well, that's the time to stop it. So I think using the test does not have to be synonymous with escalation. It has to be a tool for fine-tuning treatment.
Thank you.
Final quick question.
Concerning the pneumonia panel, is there a study analyzing how many decisions were incorrect when they were looked at retrospectively based on the test result?
Well, that's a very interesting question. Well, what is the wrong result? The best or the closest we have to this would be a clinical endpoint study. INHALE was the only study so far that has done that. But with all the innovation that we see around us in clinical trials going forward, I am sure more to come, and perhaps fine-tuned endpoints. We know, you and I, that patients fail treatment for many reasons, whether it's because of antibiotics or other things. So the closest or the only example I can think of where you would say the patient may have received the wrong treatment is a clinical endpoint. The rest, identified patients where, as you heard, treatment changes.
So, thank you very much. We have to finish, we have to close our session. Thanks a lot to the speakers for the outstanding talks. And also for the very, very, very outstanding discussion. And of course, thank you to Professor Sanguinetti from Roma, and thank you all for joining the symposium, and have a nice afternoon at the Congress and a very pleasant stay further in Vienna. Thank you very much.